Our third speaker is actually Dr. Rita Horvath from Australia, and she's actually a full professor and laboratory director in Australia and in Sydney, and she's actually a member of the IFCC task force on COVID-19 and has been very active in this area. She has extensive background in the area of evidence-based medicine, as well as or laboratory medicine, as well as guideline development. Her current position is specifically is clinical director of chemical pathology in New South Wales Health Pathology at the hospital called Prince of Wales Hospital in Sydney. And she's going to present to us on both biochemical and hematological monitoring, which is clearly very important, especially in hospitalized patients with COVID-19. Rita, please.
Thank you very much, Khosrow, and welcome everybody online. It's my privilege to present to you today about the biochemical and hematological monitoring of patients with COVID-19 on behalf of the IFCC Task Force on COVID-19. I would like to acknowledge my colleague Simon Thompson, who worked very hard together with the committee to develop this chapter of the guideline, which I'm going to present to you today. So first of all, my lecture will start with a brief description of the pathophysiological background of SARS-CoV-2 infection and the disease caused by it, COVID-19, in order to offer a rationale for the clinical indications for testing and for the selection and interpretation of routine laboratory tests. I will go through a few laboratory tests and their interpretation in the context of COVID-19, and will end this talk by discussing the limitations of biochemical and hematological tests when monitoring patients with COVID-19. First, a little bit about the pathophysiology of infection and the disease. Viral invasion of cells by this novel coronavirus requires the co-expression of host cell receptors, such as the angiotensin converting enzyme 2, ACE2, and the transmembrane serine protease 2 to be co-expressed. Cleavage of the spike protein by this protease is necessary for binding of SARS-CoV-2 to ACE2 receptors. In addition to the lung, ACE2 is also expressed in the small intestine, the kidneys, heart, thyroid, testes, and adipose tissue. And this partly explains why these organ systems are often affected during viremia. Host immune response presents the first line of physiological defense against SARS-CoV-2 infection. Damage-associated and pathogen-associated molecular patterns, so-called DAMPs and PAMPs, released during virus-induced cell death, initiate a pro-inflammatory response that leads to the secretion of various cytokines and chemokines and subsequent activation of late-phase antigen-specific T-cell recruitment to destroy virally infected alveolar cells. Apart from these immunological responses, seroconversion, 7 to 14 days after symptom onset, producing neutralization antibodies successfully clears the virus in most cases. However, viral infection can also progress to more severe disease in vulnerable populations due to dysregulated immune response, and in severe cases, the so-called cytokine storm that leads to extrapulmonary manifestations and multi-organ failure. In my talk, I will focus on these latter two stages of COVID-19 and how laboratory testing can assist in managing patient care in this severe disease. Routine laboratory tests are used to diagnose a tissue injury related to consequences of viral infection, but they are not, and in fact they cannot be used for the diagnosis of the infection per se. As you have heard in the previous discussion, for diagnosis, the reference method is RT-PCR testing at the moment. So routine laboratory tests can be used for assessing which patients are at lower risk of severe disease and can be, for example, sent home or managed in the community, or which patients really need an intensive care or require ventilation, or to identify who may even die. So it really is testing for risk of either low risk or high risk of adverse outcomes. These routine tests are also very useful for monitoring the progression of COVID-19 and the response of patients to therapy. In the rest of my talk, I will discuss the most commonly described laboratory abnormalities observed in COVID-19 patients, including inflammatory, hematological, or coagulation, liver, kidney, and cardiac biomarkers and their typical response to SARS-CoV-2 infection. The development of a sustained and progressively systematic pro-inflammatory condition, the so-called cytokine storm, has been associated with higher risk of requiring intensive care and suffering fatal outcomes. The degree of elevation of these biomarkers often correlates with the magnitude of the immunological response to the viral load and poor patient outcomes. Therefore, the measurement of some traditional inflammatory biomarkers is particularly important for early and accurate identification of COVID-19 patients at higher risk of unfavorable progression. So which are these inflammatory biomarkers that IFCC recommends that routine laboratories measure? One of the first or most commonly reported ones is obviously CRP. It's commonly measured as a non-specific biomarker of inflammation, and its increase has consistently been shown to be associated with poor outcomes in SARS-CoV-2 infection. Erythrocyte sedimentation rate might be considered by many laboratories now as an outdated test, but still it's a non-specific inflammatory marker, and particularly in resource-limited environments, its use can be recommended as an alternative to CRP. And it shows a very similar relationship to CRP in terms of higher values associated with adverse outcomes. Procalcitonin may be beneficial in identifying individuals with bacterial co-infection who may require specific antibiotic therapy and who have adverse prognosis. We don't necessarily recommend procalcitonin to be measured routinely because it doesn't necessarily add more than what you already learned by monitoring CRP. Ferritin is known to be a positive acute phase reactant, which is easily measured in most routine laboratories and could be a marker of adverse outcomes in individuals infected with COVID-19. So these are all easily accessible and relatively cheap laboratory tests for most routine laboratories. Now, IL-6 and a number of other cytokines have been measured in many studies, and they have been shown consistently across various studies to be a sensitive marker of inflammation. It has been strongly associated with severe infections and mortality. However, its added value over the traditional inflammatory biomarkers is unclear, and the test is not available in most laboratories. Therefore, its routine measurement is not recommended by IFCC at this stage, and we recommend its use mostly for research settings. Now, moving to the hematological biomarkers. Lymphopenia is probably the hallmark of SARS-CoV-2 infection. Its magnitude correlates with disease severity. The mechanisms behind progressive lymphopenia in severe COVID-19 remain unclear, although T-cell redistribution via pulmonary recruitment, exhaustion, as well as depletion through TNF-mediated apoptosis or even direct cytopathic injury have been suggested. Low eosinophil count is frequently seen in infected individuals. Significant elevations in neutrophils and a high neutrophil to lymphocyte ratio appears to be a very useful prognostic indicator by discriminating between severe and non-severe infection, and it helps guide patient management and monitoring response to treatment. In addition to the dysregulation of immune response in COVID-19 and the close association of mortality with markers of hyperinflammatory state, several reports have emerged that describe hypercoagulability leading to thrombotic events, especially venous thromboembolism and pulmonary embolism in hospitalized patients. In one recent meta-analysis, the prevalence of venous thromboembolism was 30%. For DVT, it was 20%, and for pulmonary embolism, it was reported up to 18%, which is quite a high proportion, as you can see. Patients with COVID-19 are also at increased risk of arterial thrombosis, including ischemic stroke, myocardial infarction, and limb ischemia. Immunothrombosis with pulmonary intravascular coagulation and vascular occlusion in the microcirculation of the lungs are frequent findings in autopsies of patients who died from COVID-19. Several reports also demonstrated the presence of antiphospholipid antibodies, or in other terms, lupus anticoagulant, with prolongation of the activated partial thromboplastin time. In the most severe cases, with often fatal outcomes, typical coagulation profiles for DIC, disseminated intravascular coagulation, have been described, which is most probably due to the pro-thrombotic effects of inflammatory cytokines, endothelial damage, and the activation of the complement pathway that can initiate the coagulation cascade. Neutrophil extracellular traps are also linked to COVID-19 thrombosis by activation of the intrinsic pathway of coagulation. In line with the described pathophysiology of a hypercoagulable state, the following coagulation tests were found to be useful in diagnostic and prognostic applications. D-dimer is probably the most frequently reported to be elevated, and it is clearly more elevated in severe than in non-severe disease. Prothrombin time and APTT are often normal or mildly abnormal. The APTT is also often reported as shortened, potentially due to acute phase elevations in fibrinogen and factor VIII. Both prothrombin time and APTT get prolonged in severe cases and during disseminated intravascular coagulation due to consumption of clotting factors. APTT has been shown to be prolonged when antiphospholipid antibodies or lupus anticoagulant appear transiently as part of the inflammatory response. Fibrinogen is commonly elevated as an acute phase reaction to inflammation, but when it is decreased in COVID-19, it heralds the development of DIC. Likewise, low platelet count is often observed in severe cases and when DIC develops, and thus is a marker of poor prognosis. In a meta-analysis of Chinese COVID-19 patients, D-dimer concentration was 0.67 micrograms per ml, and almost 30% of COVID patients showed elevated D-dimer values. Tang and his colleagues investigated coagulation parameters in 162 survivors and 21 non-survivors. In non-survivors, they found more elevated D-dimer, and if you look at the green lines, more elevated D-dimer and fibrin degradation products, FDP, than in non-survivors, and the non-survivors are labeled by blue on this graph. In non-survivors, they also found more elevated prothrombin time, again look at the green lines, and somewhat elevated activated partial thromboplastin time, and lower fibrinogen and antithrombin 3, all potentially due to the consumption, coagulopathy, and potential development of DIC induced by the pro-thrombotic effects of inflammatory cytokines. In line with the evidence that COVID-19 may progress to systematic disease, cardiac involvement may frequently develop in patients with SARS-CoV-2 infection as a result of direct cytopathic injury, cytokine damage, ischemia, or even exacerbation of pre-existing cardiac diseases. Malabsorptive cytokine release can directly affect cardiomyocytes and lead to endothelial dysfunction, myocarditis, and stress-related cardiomyopathy due to respiratory failure and hypoxemia. Several studies have shown that cardiac troponins are higher in patients with more severe illness compared to those with milder disease. In a study in New York, troponin I was measured within a day of admission in patients admitted to hospital with COVID-19, and the hazard ratio for death was nearly twofold in those with moderate to severe elevation of troponin I compared to the group with mild troponin I elevations. Similar relationships have been seen for other cardiac biomarkers, including creatine kinase MB, fraction, myoglobin, and natriuretic peptides, although these analyses do not necessarily add further clinical value to that already provided by cardiac troponins. The American College of Cardiology pointed out that increased cardiac troponins and NT-proBNP do not necessarily suggest acute coronary syndrome or heart failure and need to be interpreted in the right clinical context and with the key presenting features of the COVID patient in mind. An elevated cardiac troponin in COVID-19 is likely to reflect an acute myocardial injury induced by either the virus or host immune system rather than the myocardial infarction due to rupture of an atherosclerotic plaque. Of course, as a lot of patients who develop severe COVID-19 symptoms are actually having comorbidities and mostly cardiovascular comorbidities, there is always a bit of a challenge to differentiate between ACS, acute coronary syndrome, caused by the underlying disease, or cardiac damage caused by the inflammation in COVID-19. So that's why the context and the clinical context in which tests are interpreted are extremely important. IFCC recommends the measurement of troponin I or T as part of the assessment of disease severity, and patients with elevated troponin are likely to require increased levels of care and are at a much higher risk of poor prognosis. Now moving to liver function tests. COVID-19 can be associated with liver injury during disease progression and treatment in patients with or without pre-existing liver disease. Elevated values of AST and ALT and bilirubin and low albumin and prealbumin concentrations have all been associated with poor outcomes. Patients with abnormal liver function tests, particularly elevated ALT and AST, also had significantly higher risk of developing severe pneumonia. In addition, some antiviral drugs used in the treatment of COVID-19 were found to be associated with elevated liver biomarkers. So for these reasons, at a minimum, we recommend monitoring ALT, bilirubin, and albumin during treatment of patients with hepatotoxic medications and in those with pre-existing liver disease. And some recommendations suggest that this needs to be done at least twice a week during the inpatient stay of the patient. A meta-analysis of 20 retrospective studies of over 3,000 COVID-19 patients, of whom 42% were severe and 58% were mild cases, assessed the association between liver injury and disease severity. This study has found somewhat higher and statistically significant serum values of AST with a weight mean difference of only around 9 units per liter, and ALT with a weight mean difference of around 7 units per liter, as you can see on the meta-analysis graphs, and slightly higher bilirubin with a weight mean difference of only around 2 micromoles per liter, and a lower albumin with a weight mean difference of -4 grams per liter, associated with a significant increase in the severity of COVID-19 infection. As you can already hear from all these values, the weakness of the study is that the magnitude of change in these parameters was often pretty small between the groups, sometimes within the upper reference limits even of the test. Therefore, one has to be very careful when such results are interpreted against population reference intervals. It's better to monitor these parameters compared to the patient's baseline and assess progression that way. Now we move to the kidney biomarkers. Renal involvement is frequently observed in COVID-19, varying from mild proteinuria and minor serum creatinine elevations to even acute kidney injury and renal failure. The mechanisms are not fully known, but as ACE2 receptors are expressed in the kidneys, it's possible that direct viral infection of the renal epithelium results in mitochondrial dysfunction, acute tubular necrosis, and proteinuria. In addition, cytokine release, thrombosis, tissue hypoxia may all lead to intrarenal inflammation, increased vascular permeability, and volume depletion, hypovolemia. A meta-analysis of 5 studies by Giuseppe and his team in Italy with a sample size of over 1,400 COVID-19 patients found that COVID-19 severity was also associated with lower serum concentration of sodium, potassium, and calcium, and they haven't seen much change or significant changes in chloride. Another case series of over 300 Mediterranean patients has also found hypokalemia as a sensitive biomarker of disease severity and invasive mechanical ventilation requirement in COVID-19 pneumonia. Regarding other biomarkers, lactate dehydrogenase is often reported to be elevated in COVID-19 patients. Whilst we know that this is a non-specific marker of tissue damage, higher enzyme activity strongly correlates with poor outcomes. As in any patient suffering from acute respiratory distress and multi-organ failure requiring ventilation and treated in ICU, arterial blood gas monitoring is part of standard care and essential in managing patients treated for COVID-19. Many studies have reported strong correlation between elevated concentration of various cytokines and poor outcomes. However, measurement of IL-6, presepsin, MCP3, IP10, and many more cytokines that are published in research articles is not essential in routine follow-up of patients, and therefore we recommend restricting their use to research settings only. Now I show you a couple of clinical risk scores which you may have heard of, because they are very attractive alternatives, either for prognosis or diagnosis. So several clinical risk scores, such as the COVID-GRAM and the 4C mortality score, developed in China and in the UK respectively, have been developed to predict critical illness or mortality. These risk calculators use a number of simple laboratory tests and other patient characteristics to predict the prognosis of patients and admission. Others developed systems using modeling for the rapid detection of SARS-CoV-2 infection based on simple and routinely available laboratory and imaging tests, such as the Dutch Corona score, the diagnostic sensitivity of which, even though was found relatively high in the Netherlands, but when it was repeated and when this was applied in a US population setting, the sensitivity decreased quite rapidly to a much lower value. That's again just highlighting what Professor Adeli was mentioning, that you really have to verify most of the tests that you are applying in your setting, because some of the published papers represent patient populations who have a much different prevalence or much different disease characteristics. Others develop systems using modeling for the rapid detection of SARS-CoV-2 infection based on these simple laboratory and imaging tests. And there was another model called the decision tree model using machine learning that integrates age, gender, race, and routine laboratory blood tests. In other words, again, very simple parameters that are readily available in most routine laboratories within a short turnaround time in order to predict infection status. The main weakness of these scoring systems is that they are developed on a certain subset of cases in countries where the prevalence and severity of the disease could grossly differ, Therefore, until clinical risk scores are validated in large independent populations in whom these tests are to be used, we would advise you against using these score algorithms to diagnose or risk stratify COVID-19. Finally, a few words of caution in terms of test interpretation and limitation of laboratory testing. Routine laboratory test results should not be considered in isolation. No one test is specific enough for the diagnosis, triage, or prognostication of COVID-19. All relevant tests should be interpreted in the context of patient's clinical presentation, the actual prevalence of the condition in the community, the clinical history of exposure. Differences in test results may be minor, as you have seen, for example, with the liver function tests, yet still could be clinically significant. Therefore, big care should be taken to avoid misinterpretation of small changes in results. Longitudinal monitoring of results may be more informative than considering a single result in the context of the reference interval, again, just as I illustrated to you with the AST, ALT, bilirubin examples. Cutoffs, decision limits in published studies should not be adopted without first ensuring their appropriateness for their use in the intended laboratory or environment. And you have to be very much aware of method-related and population-related variation in test performance. So I'm not going to go into details with the summary recommendations, which basically cover all what I have just said before in a table format. You will find it in the IFCC guideline, and you are very welcome to use it. And all the references that this lecture was based on are listed for your future reference. And finally, I just would like to thank you. Keep safe, wash your hands, wear your masks, and just look after your loved ones. Thank you.